Right now, somewhere in America, a brain is beginning to change. Not dramatically, not obviously, quietly. Words that used to arrive instantly now take a half second longer. A familiar name floats just out of reach. A route that was automatic suddenly requires a moment of thought. And the person experiencing this believes they are perfectly fine. The 2024 Lancet Commission, the most comprehensive global review of dementia science ever published, identified something that should fundamentally change how every person over 60 thinks about their brain. 45% of all dementia cases worldwide are preventable. Not 10%, not a quarter, nearly half. And the window to act is open right now, for most people watching this video. Stay with me, because at the end of this video, I'm going to reveal something about a completely unexpected source of Alzheimer's risk, one that affects 70% of Americans over 65, that almost no physician discusses at a standard appointment. It begins in your mouth, and it ends in your brain. My name is Dr. Chandler. I specialize in gerontology, the neuroscience of how the brain ages after 60, and the interventions that change that trajectory. And I want to begin with the research that anchors everything we are going to discuss today. The 2024 Lancet Commission on Dementia Prevention, led by Professor Gil Livingston and colleagues at University College London, reviewed decades of global epidemiological data and identified 14 modifiable risk factors responsible for 45% of all dementia cases. Modifiable, meaning changeable, meaning within reach. Today, I am going to focus on the 5 that carry the greatest cumulative weight for adults, specifically over 60, with the precise biological mechanisms that explain why each one matters more in your decade than in any decade before it. And I will show you 2 specific tests you can perform on your own body, right now in the next few minutes, that will give you an honest picture of where your cognitive reserve stands today. But first, I need to show you what is actually happening inside the aging brain, because once you understand the mechanism, everything else becomes clear. Here is the timeline that most physicians never explain to their patients. Alzheimer's disease, the most common form of dementia, does not begin when the diagnosis is made. It begins 15 to 20 years earlier, sometimes more. The proteins that eventually form the toxic plaques and tangles inside an Alzheimer's brain, amyloid beta and tau, begin accumulating silently during the decade when most people feel sharpest, most capable, most certain that their brain is fine. A landmark study published in Nature Neuroscience by Bateman and colleagues used PET imaging to document amyloid accumulation in cognitively normal adults, people with no symptoms, no complaints, no concerns, and found measurable toxic protein buildup beginning on average 22 years before clinical dementia onset. 22 years. That means the biological decisions you make in your 50 seconds and 60 seconds are actively writing the story your brain will tell in your 70 seconds and 80 seconds. And the 5 factors I'm about to describe are not theoretical risks. They are the exact biological processes through which that story gets written. Day by day, silently, without pain, without warning. Process 1. The glymphatic shutdown, what your brain does at night, that you are preventing. Most people believe that the brain rests during sleep. It does not rest. It cleans. In 2013, researchers Lulu C. and Maiken Nedergaard at the University of Rochester published a discovery in Science Journal that fundamentally changed neuroscience. They identified a previously unknown system of fluid channels in the brain, now called the glymphatic system, that activates almost exclusively during deep sleep. This system uses cerebrospinal fluid to flush the exact toxic proteins, amyloid beta and tau, whose accumulation defines Alzheimer's disease. During deep sleep, these channels expand by up to 60%. Fluid flow increases tenfold. The brain processes in an hour of deep sleep what it cannot process in 12 hours of wakefulness. Now here's what the research shows specifically about the aging brain. A 2021 study published in Nature Aging by Mander and Walker at UC Berkeley documented that slow-wave sleep, the deepest, most restorative phase, decreases by approximately 75%, between the ages of 25 and 75. 75%. For a 65-year-old already sleeping less efficiently, this means the glymphatic system is operating at a fraction of its cleaning capacity every night. Amyloid proteins accumulate, not because the brain is producing more, but because the clearance mechanism has been compromised. A 2017 study in JAMA Neurology, Ju and colleagues at Washington University, confirmed that even a single night of sleep disruption produces measurable increases in amyloid beta concentration in the cerebrospinal fluid of cognitively normal adults. One night. Measurable increase. Here is what to do. 3 senior-specific interventions. First, establish a fixed wake time, not a fixed bedtime. The brain's sleep architecture is anchored to the time you wake, not the time you attempt sleep. Consistency in wake time regulates the circadian system more powerfully than any other single behavior. Second, lower your bedroom temperature to 65 to 67 degrees Fahrenheit. Research from the National Sleep Foundation confirmed this specific range maximizes slow-wave sleep duration in adults over 60, the phase where glymphatic activity peaks. Third, elevate the head of your bed by 4 inches. Research published in the Journal of Neuroscience by Lee and colleagues confirmed that a slight head-elevated body position during sleep enhances glymphatic fluid flow compared to sleeping completely flat. The brain will clean itself, if you give it the conditions to do so. Stay with me, because Process 2 reveals something about a sense most people consider completely unrelated to cognitive function, and the research will genuinely surprise you. Process 2. Auditory cortex starvation, the sense that feeds the brain. Most people believe hearing loss is an inconvenience. The research says it is a neurological emergency in slow motion. Here is the mechanism. Specific to a brain over 60, your auditory cortex, the brain region that processes sound, does not simply receive audio information. It actively generates neural activity that spreads across interconnected regions. The prefrontal cortex, the hippocampus, the parietal association areas. Sound is a continuous, complex stimulus that keeps large portions of the brain active and connected. When hearing loss narrows that input, those regions begin receiving less stimulation. And the brain's fundamental operating principle, as confirmed across decades of neuroimaging research, is precisely this. Neural connections that are not activated regularly are pruned and lost. A major analysis published in The Lancet, Thompson, Livingston, and colleagues, found that untreated hearing loss raises dementia risk by a factor of 1.9, nearly doubling the baseline risk. For a 65-year-old senior with moderate untreated hearing loss, that is not a marginal increase. It is clinically equivalent to carrying one of the strongest modifiable risk factors in the entire dementia literature. Unaddressed. But here is the piece most scripts miss entirely. Hearing loss accelerates cognitive decline more severely in adults over 60 than in younger adults, specifically because the aging brain has diminished neural reserve, less redundant capacity to compensate for degraded input. A 45-year-old brain can partially compensate for reduced auditory input through neural plasticity. A 68-year-old brain has significantly less compensatory capacity to draw on. Here is what to do. Request a formal audiological evaluation, not a screening at a pharmacy kiosk, a clinical audiogram with a licensed audiologist. A 2023 randomized controlled trial in The Lancet, the ACHIEVE study by Lin and colleagues, confirmed that hearing aid use in adults with moderate hearing loss reduced cognitive decline rate by 48% over 3 years in participants with elevated baseline risk. A hearing aid is not a symbol, it is a brain protection device. Process 3. The myokine deficit, what your muscles are making for your brain. Most people believe exercise prevents dementia because it improves cardiovascular health. That is true, but it is the least interesting reason. Here is what the research discovered, and what almost no one outside of neuroscience circles knows. Your muscles are an endocrine organ. They produce and secrete signaling molecules called myokines that travel through the bloodstream and directly influence brain biology. The most important of these is a myokine called irisin. When muscle contracts during physical activity, it releases irisin into circulation. Irisin crosses the blood-brain barrier and directly stimulates the production of BDNF, brain-derived neurotrophic factor, the primary growth factor for neurons. BDNF promotes the formation of new neural connections, protects existing neurons from degeneration, and specifically supports the hippocampus, the brain region first and most severely damaged by Alzheimer's disease. A 2013 study published in Cell Metabolism, Vraan, Spiegelman, and colleagues at Harvard established the direct irisin BDNF pathway in the brain. Subsequently, a 2019 study in Nature Medicine, Lorenzo and colleagues at the Federal University of Rio de Janeiro found that irisin levels in the cerebrospinal fluid of Alzheimer's patients were significantly lower than in cognitively healthy controls, and that restoring irisin levels in animal models reversed memory impairment. Here is the senior-specific critical detail. After 65, BDNF production from exercise is blunted by approximately 30% compared to younger adults. The myokine signal is weaker. This does not mean exercise stops working. It means the minimum effective dose is not the same as it was at 45. Research published in the Journal of Alzheimer's Disease, Erickson and colleagues, confirmed that in adults over 65, the threshold for measurable hippocampal volume preservation through exercise requires consistency over months, not occasional effort. Here's what to do. Here is what to 30 minutes of moderate aerobic movement. Brisk walking, cycling, swimming, 5 days per week. Specifically, aerobic. Resistance training produces different myokines and is additionally beneficial, but aerobic exercise is the primary irisin BDNF driver. The research does not require a gym. It requires a sidewalk and consistency. Now, before I share process 4, I want you to do something specific right now on your own body. Stand up if you are able to do so safely. Begin walking slowly across the room. While walking, like say the months of the year backward, December, November, October, September, continuing while you keep moving. Here is what you are looking for. Did you slow your walking pace significantly to think? Did you stop walking entirely? Did you lose your place in the months? This is called the dual task cost test. Research published in Neurology, Verghese and colleagues, confirmed that the inability to maintain walking speed while performing a cognitive task simultaneously predicts dementia onset 5 to 7 years before clinical symptoms appear. The hippocampus and prefrontal cortex must work in coordination to manage movement and cognition simultaneously. When that coordination is beginning to degrade, the walking slows first. If you stopped walking to think, that is not a reason to panic. It is a reason to prioritize everything in this video. Now, process 4. Process 4. The insulin-brain disconnection. Why some researchers call Alzheimer's type 3 diabetes. Most people believe insulin is about blood sugar. What the neuroscience reveals is that insulin is also a critical signaling molecule inside the brain itself. Insulin receptors are densely distributed throughout the hippocampus and prefrontal cortex, the regions most vulnerable to Alzheimer's disease. Insulin in the brain does not manage glucose in the same way it does in muscle or fat tissue. It performs a different function. It regulates neurotransmitter activity, supports synaptic plasticity, and protects neurons from oxidative damage. When brain insulin resistance develops, imagine when neurons stop responding to insulin despite its presence, those protective functions fail. Synaptic connections weaken. Neuroinflammation increases. Toxic protein accumulation accelerates. This is why leading researchers, including Suzanne de la Monte at Brown University, whose work was published in the Journal of Diabetes Science and Technology, proposed calling late-onset Alzheimer's disease type 3 diabetes, a form of insulin resistance that develops specifically in brain tissue. A 2005 study published in Diabetologia, Luxinger and colleagues, found that adults with insulin resistance had a 65% increased risk of developing Alzheimer's disease over a 4-year follow-up period, independent of other risk factors. For seniors specifically, Postmenopausal women and adults over 65 with abdominal obesity show the fastest progression of brain insulin resistance, documented in research from the Mayo Clinic, due to the combined effect of declining sex hormone levels and elevated visceral fat-driven inflammation. Here is what to do. 2 evidence-based daily interventions. First, eliminate liquid calories completely: juice, sweetened coffee, soda. These produce the fastest, most aggressive insulin spikes of any dietary source. And research published in Alzheimer's and Dementia confirms that chronic glucose spiking accelerates amyloid accumulation, specifically in the hippocampus. Second, add a 10-minute walk within 30 minutes of your largest meal. A 2022 meta-analysis in sports medicine confirmed that post-meal walking reduces the postprandial glucose spike by an average of 22%, directly reducing the insulin demand that drives brain insulin resistance over time. Stay with me, because what I am about to reveal changes how you think about every dental appointment you have ever skipped. In 2019, a research team led by neurologist Stephen Dominy, publishing in the journal Science Advances, did something that had never been done before. They examined the brain tissue of deceased Alzheimer's patients directly, not looking for amyloid, not looking for tau tangles, looking for something else entirely. They were looking for bacteria. What they found stopped the scientific community. Porphyromonas gingivalis, the primary bacterial driver of chronic gum disease, was present in the brain tissue of 96% of Alzheimer's patients examined. Not occasionally, not incidentally, 96%. The same team found that this bacterium produces toxic enzymes called gingipains, which directly damage brain tissue, trigger neuroinflammation, and promote the formation of both amyloid beta and tau tangles, the 2 proteins whose accumulation defines Alzheimer's disease. How does a gum disease bacterium reach the brain? When gum tissue is chronically inflamed, as it is in the 70% of American adults over 65 who have some degree of periodontal disease, according to CDC data, the barrier between the gum and the bloodstream is compromised. Porphyromonas gingivalis enters the bloodstream directly through inflamed gum tissue. It has also been shown to travel along nerve pathways, including the trigeminal nerve, reaching the brain directly without entering general circulation. Once inside the brain, it does not cause an acute infection. It causes a chronic, low-grade inflammatory response. Exactly the neuroinflammatory environment that accelerates every form of cognitive decline. A follow-up study published in Alzheimer's Research and Therapy, Ilievsky and colleagues, confirmed that in animal models, repeated oral exposure to Porphyromonas gingivalis produced measurable amyloid beta accumulation in the brain within weeks. A 2008 study published in the Journal of Alzheimer's Disease, Kammer and colleagues, found that the presence of antibodies against periodontal bacteria was associated with significantly elevated amyloid beta burden in cognitively normal adults. Your toothbrush is a dementia prevention tool, and most people are using it incorrectly or not consistently enough for it to matter. Here is the senior-specific oral protocol that the research supports. First, brush for a full 2 minutes, twice daily, not once. A 2016 Cochrane review confirmed that electric toothbrushes reduce gingival inflammation significantly more than manual brushing in adults over 60, where manual dexterity and grip strength may compromise brush effectiveness. Second, floss or use a water flosser daily. The space between teeth is where Porphyromonas gingivalis colonies are densest. No toothbrush reaches there. This is non-negotiable. Third, schedule a professional dental cleaning every 6 months, not every year. Periodontal disease in seniors progresses faster due to reduced immune response in gum tissue. A 6-month interval is the minimum evidence-based standard for adults with elevated periodontal risk. Fourth, oil pulling, 15 minutes of swishing with coconut oil before brushing, has been shown in a randomized controlled trial published in the Journal of Traditional and Complementary Medicine to reduce Porphyromonas gingivalis colony counts by up to 20% within 4 weeks. Inexpensive, evidence-based, 15 minutes while you make your morning coffee. Now, before your second self-test, I want to share one case from clinical practice that ties everything together. A 64-year-old woman, I will call her Margaret, came to a geriatric specialist with one specific complaint. She was losing words, common words, words she had used her whole professional life. Her evaluation revealed 5 compounding factors: moderate, untreated hearing loss, diagnosed but never addressed, chronic poor sleep averaging 5 hours per night due to anxiety, a sedentary lifestyle following retirement, visceral obesity with borderline insulin resistance on blood work, and periodontal disease her dentist had documented twice but she had never treated. No single factor on its own was dramatic. Together, they represented 5 simultaneous streams of neurological erosion running for an estimated 8 to 10 years. Her neurologist addressed 3 concurrently: hearing aids fitted within the first month, cognitive behavioral therapy for sleep within 6 weeks, and a structured walking program. Dental treatment began in month 2. At the 18-month review, her cognitive assessment scores had stabilized. Word retrieval had measurably improved. Her neurologist documented her case as successful early intervention, not reversal, but a genuine change in trajectory. The difference between Margaret's outcome and a different outcome was one thing: she acted before the window closed. Now, your second self-test. Place your dominant hand on your thigh. Tap your index finger to your thumb as rapidly as you can, maintaining contact each time, for 10 seconds. Count the taps. A published normative reference from Neuropsychology Journal, Ruff and Parker, established that cognitively healthy adults aged 60 to 70 average between 55 and 70 taps in 10 seconds. Below 50 taps may indicate early fine motor cognitive coordination changes worth discussing with a neurologist. This is not a diagnosis, it is a data point. Take that data point seriously enough to act on everything in this video. I want to hear from you directly. How old are you? And which of these 5 processes surprised you most? Leave your age and your answer in the comments right now. I read every single one. And this community shapes every video I create next. If someone you love is over 60 and has never connected their dental health, their sleep, their hearing, or their muscle mass to their brain, share this video with them today. Early is the only strategy that works for this. Now, if your brain insulin resistance is already developing, there is one specific blood marker your physician almost certainly has not ordered that predicts Alzheimer's risk 10 years before any symptom appears. It is not on a standard panel, but you can request it by name. Watch this video next. I will tell you exactly what to ask for and what the number means.